My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
Okay, well, thank you for inviting me back. I really love to talk about research advances, and so this year is no exception, so thanks for the invitation. So for those of you who listened to Brian's talk last week, we did coordinate, so hopefully this won't be a review, although I may remind you of a couple things that he said just in the way of background. So people who practice HIV medicine and especially are familiar with the major research clinical advances that were talked about at CROI are well aware that dolutegravir has become incredibly popular in the United States. Recently, it actually became first-line antiretroviral therapy in Brazil, and there will be a generic form of dolutegravir, TAF, and 3TC that will be available in resource-limited settings probably by the end of this year. Ironically, it won't be available in the United States, but that's actually not surprising. Resource-limited settings actually were far ahead of the U.S. in fixed-dose combinations like this one and others for years before that type of advance in formulation became available for patients in the U.S., much to the chagrin of many of the practitioners like you guys and me. What you did hear from Brian was that dolutegravir monotherapy as a switch strategy is suboptimal, and you heard the details about that last week, and I'm not going to talk about those further. And then I know also you heard about at least one of the 2 drug regimens that has attracted interest in the research community, both by presentations at CROI, including the one you heard about a few weeks ago, dolutegravir and rilpivirine, and there also was some information that I'm going to talk a little bit about cabotegravir and rilpivirine. There are, in data that were referred to but not presented, there were also discussions about darunavir boosted with ritonavir plus 3TC, and there have been 3 studies in Europe that suggest that that is non-inferior to a 3-drug regimen, although it, I think, has not become commonly used yet, certainly in the United States, and I'm not sure even in most European countries except the centers which did those studies. And then lastly, dolutegravir and 3TC is attracting enormous interest on the basis of some one very striking but teeny phase 1 study. There are some large phase 3 studies underway, although there are still multiple questions about whether the durability of response, the effect on reservoirs, and the very low level viremia that many patients with HIV who have below detectable viremia on standard assays, what these dual drug regimens are going to do in that setting, and the inflammation that we know that can occur despite suppressed HIV in some places, and clearly what the cost is going to be, which is one of the major drivers of interest in 2-drug regimens. But we have to, I think, wait and see what happens, especially in the U.S. with respect to cost. So those are like big picture trends, and now we're going to talk a little bit more about why there's a need for additional antiretroviral therapy. With as many drugs as we have, I think that's a decent question. Why should resources be spent on developing new regimens? Beatrice Grinstein, who is a physician and investigator from Brazil, whose picture is now on your screen, gave a really eloquent talk that was really outstanding with respect to the issue of why new drugs are needed. And the major messages that I think she communicated, including if we had simpler regimens with lower doses, then they might have better safety profiles and be cheaper. She argued very strongly that we need better drugs for pediatrics and adolescents, where the drug development really lags, and the regimens that they consider their first line, we in adult HIV have sort of discarded as first line regimens years ago. Having more fixed drug combinations would be helpful, and having, globally especially, having regimens that can be more universal for all the patients that need treatment. In particular, drug-drug interactions in many resource-limited settings are a problem with TB being so prevalent. So drugs that don't interfere with rifampin or rifampin that doesn't interfere with the drugs would be a real benefit. And certainly we have some drugs like that, but not currently, at least in the US, ones that we would consider first line. Certainly drugs that could be better safety in pregnancy or breastfeeding for breastfeeding women, and safer antiretrovirals for individuals with multiple comorbidities who need multiple medicines. And then lastly, better resistance profiles. So we don't have a universal drug, even though sometimes it seems like with drug du jours or regimens du jours that there is a huge shift from what used to be our regimen du jour with the efavirenz-based regimens now to dolutegravir regimens. But I think there still is a need for drugs that might help us with specific populations. So that's the rationale for new drug development. The most exciting new drug development that was described at CROI, at least in my opinion, is a drug that has not yet been seen in humans, but which is actually a new class of antiretroviral drugs, an HIV capsid inhibitor. And there's a picture in the upper right of the HIV capsid, which is that sort of mango-shaped thing in the middle of the small particle that's supposed to represent an intact infectious HIV particle. The exciting thing about this capsid inhibitor is that it inhibits HIV at multiple steps in the life cycle, both the disassembly of the capsule when HIV enters a new cell, so at a stage supposedly between the reverse transcriptase and the integration step, and also at the late in the life cycle when the capsid is being created to create an infectious virus. So that's really different than most of the drugs that we have, which now currently are effective only at one step in the life cycle. This inhibitor also in vitro has some other very attractive features. It has potent inhibition, it inhibits all clades of HIV, it appears to inhibit multi-resistant HIV from clinical isolates, which makes sense since it doesn't use the same mechanisms as any of the current drugs we have. Its binding site is highly conserved, meaning that it should be able to continue to be effective, but in serial passage in vitro, it is effective in creating mutations eventually, and that's really important because if it doesn't create mutations, then drugs aren't having selective pressure and therefore probably aren't effective. So having mutations with many serial passages is actually a good thing, not a bad thing. And lastly, the pharmacokinetic data in rats suggested that it might have a prolonged half-life. So this sounds fabulous. We will see if all of the preclinical and the clinical data continue to show promise. And in my view, the less you know about a drug, usually the better it sounds. But this one at least has characteristics that I think are worthy of noting and following this through its development. There are other drugs that are also in early development that were described at CROI that have potential for being useful. DS9131 is a nucleoside reverse transcriptase inhibitor, which looks to be potent against nucleoside-resistant viruses. It in vitro doesn't inhibit the gamma polymerase, which is associated with toxicity in some of our current nucleosides. So at least that might have potential for being less toxic, and it appears to have a half-life consistent with daily dosing. There is a new protease inhibitor that is in very early development that is active against protease-resistant clinical isolates, appears to be very slowly metabolized compared to darunavir and atazanavir, and have a longer half-life than those drugs, doesn't require boosting. So we'll have to see what happens with that. A novel integrase inhibitor, which is further along in development than the previous two drugs I described, is named Bictegravir. This appears to be potent and have activity against viruses that are resistant to the currently used both first and second generation integrase inhibitors. It has oral bioavailability, doesn't require boosting, has a long half-life, has an interesting metabolism in that it's metabolized by two enzymes that we have become familiar with through other antiretroviral therapy. But the good thing about this is unless there are drugs that inhibit both of these mechanisms, there isn't a significant clinical interaction, it appears. The data that were presented about Bictegravir at CROI are shown here. The study was also simultaneously published in Lancet HIV, if you're interested in more details about it. But it was a phase 2 double-blind randomized study comparing Bictegravir to dolutegravir, both used with FTC and TAF in 91 antiretroviral individuals, mostly men. The drugs looked quite similar in terms of the adverse effects. The laboratory abnormalities were said to be mild and transient. And as you can see from the graph and also the proportion of patients with HIV RNA at 24 weeks, which was the primary endpoint of this study, these regimens looked similar. So it looks to be very effective. And so the conclusion that the investigators made has high efficacy, was well tolerated, and they have proceeded to phase 3 studies, which are ongoing. And what I found kind of interesting is that as they optimized a fixed dose combination of Bictegravir with FTC and TAF, they actually were able to lower the amount of Bictegravir that appears to be used and result in an equivalent pharmacokinetics to their previous single drug dose. So hopefully that bodes well for a smaller size pill, which we certainly could use. So we'll see. The other new drug that is relatively close to the clinic is a new NNRTI called Doravirine, and results of a phase 3 study were presented at CROI. This was, as you might expect, a large randomized placebo-controlled multinational study that enrolled 771 individuals. It compared Doravirine to a boosted darunavir with 2 nucleoside reverse transcriptase inhibitors of choice. They were provided, and 90% of the individuals in the study received tenofovir and FTC. The study looked at virologic suppression and lots of follow-up using something called the FDA snapshot approach, and I'll explain that a little bit more in a few slides, and looked to see if this new regimen was non-inferior to the darunavir regimen. They had a similar number of discontinuations due to adverse events, actually a very small one. The Doravirine arm had better lipid profiles. And here are the virologic results, which you can see looking at the proportion of virologic suppression were very similar. The Doravirine was labeled non-inferior. It did not meet the criteria for superiority, which was also evaluated after it was found to be non-inferior to the darunavir regimen. The FDA snapshot that I referred to is an analysis that looks not only at virologic suppression, which is shown in the bar graph on the lower left, but also in individuals who don't have any data at the final endpoint. So people who are lost to follow-up or don't have data within the window also count as failures. But what you can see from these 3 bar graphs, which look at the proportion suppressed below 50 on the left, the proportion that were not suppressed below 50, and then those who had no data, the similarities in the graphs show that they really had very similar metrics no matter how you slice the success or failure rates. So the conclusion of this study was this is a new, safe, potent once-daily NNRTI, and there is a plan for a fixed-dose combination. And we'll sort of see what happens as it rolls out and see whether there is still interest in NNRTI-based regimens. The other sort of trend within antiretroviral therapy are to look at drugs who are longer acting than the drugs that we heretofore have. There have been some focus group work that were referred to at CROI, but have been published previously, where patients are actually quite enthusiastic about the concept of long-acting antiretroviral therapy, much more so actually than healthcare workers, at least in the analyses that have been done so far. The idea is that if there was infrequent dosing, you might consider some kind of directly observed therapy. There might, in situations where health privacy is a problem in the home, you might, if someone didn't need to take their medicine at home but could have periodic visits to a health clinic. There might be better health privacy, less stigma. For individuals who have pill fatigue, it might be a strategy to combat that. And depending on the circumstances, maybe increased adherence, with especially associated with DOT for people who have challenges with current oral regimens, might be something that was an advantage. The thing that I found quite interesting, which many of you may already know, but there was a discussion of long-acting therapy that referred to the example of contraceptives, where if we think about it, 10 years, 20 years ago, oral contraceptives were the way to go, with less injectable, although there's certainly been one long-term injectable that has been used and still is relatively widely used, but was estimated to cover about 10 to 15% of contraceptive use. And implantable contraceptives apparently are now being used by about 50% of women who use contraceptives. So this was cited as an example of situations where long-acting therapy really took over the oral therapy in a particular niche of drugs. There clearly are multiple issues with long-acting antiretrovirals. There are different issues with injectables versus implantables, but they both have potential issues. The injectables including volume, the number of injections per dose, and then for antiretrovirals, where we need combination regimen, pharmacokinetic issues are really important. The current most advanced antiretroviral in clinical development, which we'll talk about in a minute, has a need for an oral lead-in before there is switch to the parenteral formulations. And then, given that we need combination therapy that continues to be effective, if drugs have a very, very long half-life and very long and low drug levels after they're stopped, that's a problem because of the potential for resistance. And then lastly, another significant issue would be if someone gets an adverse event to a long-acting therapy, what do you do? Nonetheless, there are several long-acting antiretrovirals in different stages of development, and multiple different pharmacology strategies are being investigated. I've told you about the capsid inhibitor. We're going to talk next about MK8591. Monoclonal antibodies fall into this category. There are some modifications of existing antiretroviral therapy that have been done and are being investigated in vitro. There is a misstyrylation of 3TC and an esterification of dolutegravir that have been designed and appear to have the potential for longer acting half-lives in animals. There are nanoformulations which have the potential to decrease cost. There is an iron-coated nanoformulation of dolutegravir that was described, and there was some modeling done to suggest that nanoformulations of efavirenz could potentially cut the dose in half and therefore potentially markedly decrease the costs. And since efavirenz is still used globally very commonly, that certainly is an attractive idea. The one that's closest to my heart, and I have to declare a conflict of interest, is something called the Targeted Long-Acting Combination Antiretroviral Therapy, or TLC-ART. This is a strategy being developed by colleagues of mine at the University of Washington, who pulled me in to be the clinical part of their drug development program, which is in the preclinical stage right now. So no humans have seen this drug or these approaches, but they have the means to put 3 to 4 drugs in a liquid nanosuspension that in several species of animals has shown prolonged plasma lymph node concentrations with subcutaneous injections. And so we'll see where that goes. Right now we're actually preparing IND to start moving toward clinical development. But drugs that are already in clinical development include MK8591. The exciting thing about this is that it has a new mechanism of action. It targets the reverse transcriptase enzyme, but it is called a translocation inhibitor. So it is not a chain terminator like all the other NNRTIs that have been heretofore. It has been shown to be potent against both strains of HIV as well as multi-drug resistant strains of at least nucleoside reverse transcriptase multi-drug resistant strains. And there were preclinical data that were shown this week showing rapid distribution to lymph nodes in rats with higher concentrations in lymph nodes and blood, and then a non-human primate model looking at once-weekly injections showing that the concentrations in blood, cells, the vagina, and the rectum are similar. So this drug has potential for both treatment as well as prevention, oral forms as well as injectable forms, and that flexibility, I think, bodes well for its future development for some HIV-related use. There has been, last year, there were presented a monotherapy single-dose study in humans that showed that this did have antiviral effect in humans also. There are lots of monoclonal antibodies in development for a variety of different purposes. The one that is most relevant for our discussion today is Pro-140, which is a humanized monoclonal antibody that is being developed for HIV treatment. And the data that were presented at CROI this year were about an optional long-term monotherapy extension for people who had been in a previous study looking at weekly dosing, and those who were successfully suppressed on this therapy alone were allowed to continue it if they wanted. And they had about 75 individuals in their first study, and of those, 16 asked to continue. 10 of those individuals are still giving themselves 2 1 ml subcutaneous injections weekly. They are not on other antiretroviral therapy. And in the data that were presented, of these 16, 10 were still on, out to basically a little over 2 years of treatment. 5 had had virologic failure and 1 had moved. And of those individuals who had had at least 2 years of treatment, 7 of the 10 had very, very suppressed virus, less than 1 copy per ml on what's called a single copy assay, a very, very sensitive HIV RNA assay. The rest had 4 to 19 copies. So the people that had chosen to stay on it are doing really well. Obviously, the people who failed aren't doing well, and so this is a highly, highly selected group. But these data, they said that in the people who'd chosen to stay on, it was well tolerated. No surprise if people would have quit if it wasn't well tolerated. But they have used this data to develop and start an ongoing phase 3 monotherapy study. So very interesting, and certainly not in the major philosophic approach that most other drug development believes is necessary, namely multiple agents. The other broadly neutralizing monoclonal antibody that's probably worth hearing about is something called VRC01, which was developed at the U.S. National Institutes of Health Vaccine Research Center. That's the VRC. And VRC01 is the first broadly neutralizing antibody that they developed. They've continued to develop others, but this is the first one that has been given to humans, and it's been given to lots, like several hundred humans. There is another one that has been given to like 5 humans. So you will be hearing about other broadly neutralizing antibodies for both cure research, namely to decrease reservoirs, treatment, as well as prevention. And the study that was presented at CROI this year was one that looked at its impact on reservoirs in people who were already suppressed with conventional 3-drug antiretroviral therapy. And they showed that this was safe. It didn't impact on low-level viremia or the amount of HIV DNA in peripheral blood mononuclear cells, but it's sort of a stay tuned kind of message because there are multiple ongoing phase 2 studies, and there's a long-acting version that is being used or will about to be used in treatment studies that are starting soon. As I mentioned, there is one double drug therapy that has garnered a lot of interest in the long-acting antiretroviral space, which is Bictegravir, which is a novel integrase inhibitor very similar to dolutegravir, and rilpivirine, which is just a different formulation of the non-nucleoside reverse transcriptase inhibitor that we know about from clinical practice. Last year, there were phase 2 studies, one called Latte, one which was of this combination orally, and then subsequently a phase 2 study presented at CROI called Latte 2 that looked at an injectable formulation that was long-acting. And What that study had shown is that both intramuscular injections every 4 weeks or every 8 weeks were comparable to oral therapy as maintenance antiretroviral therapy for people who'd been suppressed on an oral regimen. The new data about this combination include the fact that long-acting cabotegravir can be detectable in a minority of patients 52 weeks after the last injection. And that minority is estimated at approximately 20%, so it's not a trivial proportion. And that raises this issue of how do you make sure that individuals don't drop out, decide to not take other drugs. What do you do to try and help prevent low-level monotherapy for individuals getting this drug? So that's a challenge. There was a lot of discussion about what to do or what not to do. The other data that were presented about cabotegravir and rilpivirine was about the oral latte study, the first one done before the one with the long-acting. And this was also, as I just referred to another study, this was an open-label optional extension of an original oral study. This one went out to 144 weeks, and they had more people than the Pro 140 study that we just talked about. They had 138 of their original 181 participants who had been randomized to this regimen. And at 144 weeks, 76% of them had virologic suppression, 8% had virologic failures, and the rest, making up 100%, had no data. So as I had referred to, that's sort of the FDA kind of snapshot approach issue. And so you can fail because you're not suppressed, or you can fail because you stop and don't have any data. In this particular study, the oral study, 4% of individuals had drug-related adverse events, 3% total of the original 181 discontinued for side effects due to this regimen, and there weren't any drug-related SAEs for either the new regimen or the previous comparator. So they concluded that oral cabotegravir and rilpivirine was safe and well tolerated. And this sum total of data, both the injectable and the long-acting injectable and the oral data, has led to 2 multinational randomized phase 3 studies that are underway now comparing long-acting parenteral cabotegravir and rilpivirine, which are being given intramuscularly every 4 weeks. And those studies are comparing it to a conventional oral antiretroviral regimen with dolutegravir. So that's another kind of stay tuned. So if we step back and say, what are the implications for antiretroviral treatment of the data that were presented at CROI? What is clear by the fact that I've told you about a bunch of new drugs is that drug development is continuing. And as it has been since the beginning of antiretroviral drug development, I think it is likely that the antiretrovirals that we use in the clinic will continue to change over time. I didn't emphasize this, but most of the new drugs have been developed by 2 companies, and that's really quite different than the days of old where there were many more companies developing HIV drugs. So it does seem that pressure in the industry has led many companies to stop developing antiretroviral drugs. And I'm not referring to the generic companies, of which there are several, that make antiretrovirals, but they tend to license. Currently, the strategy is generally to license the drugs from the companies that initially developed them. There is clearly a high interest in fixed drug combinations, and I think we will see more of those in the United States. And I think we'll hear more about the long-acting formulations. Hard to know where they're going to go and whether they will become as popular as contraceptives have. There is also the continued potential for overlapping uses of antiretroviral therapy, both as treatment, as we've discussed here, and prevention. And there certainly were a number of presentations on prevention that I don't know if you're organizing somebody who's going to talk about that, hopefully, because that's another important use of antiretrovirals. And I think lastly, and probably most importantly, there clearly are aspects of our current therapy that don't work for everybody. And so I think there is room for agents and regimens that address specific needs or patient populations in order that all of our patients can be successful with antiretroviral therapy. like we want for them, and clearly the public health approach also is very enthusiastic about. So thank you very much for your time, and I'm certainly happy to answer any questions if you have any, or hear comments if you have them.